Hello and welcome to EACTS TV. Once again, my name is Roy Shepherd. I'm the host for this evening. I hope you had a really great second day of the virtual Congress. I've been talking to a lot of people today, actually, and there just does seem to be a fantastic camaraderie amongst everybody, a very open mindset. People have been quite understanding when things haven't gone completely to plan. Sometimes they've been a little bit slow. And I said this last night, and I'd like to repeat it. When things go slow, it isn't always the portal. Sometimes you'd be better off if you plugged in an Ethernet cable or a LAN cable so that you would get a much better signal, because the portal uses up a lot of data. So it's better than using Wi-Fi. Now, if you're new to EACTS TV, you do have an opportunity to send in comments in the chat area. If you'd like to tell us where you are or any comments you'd like to make about your experiences today, I will add that we'd like you to be kind about that. We've got lots of people that I'm going to be talking to about sessions that we've had today, sessions we're going to have tomorrow as well. Patrick Myers is the Twitter king. Welcome back, Patrick. So what has been going on? How has the Twitter sphere been handling EACTS this year?
Oh, it's been phenomenal. We're just on day 2. That's just finished now. And we're up to 9.5 million impressions this evening.
That is remarkable. That really is incredible. What sort of things are trending?
Well, it's really just everybody going out, watching the sessions, and then giving us their impression of what they've seen. Now, of course, some of our Twitter ambassadors are very active. As you saw, Jessica Luke, who was on last night. I don't know how she gets out 849 tweets in 2 days, but anyhow, she is, as always, phenomenally productive. But also we have
incredibly enthusiastic as well. So I'd like some of that energy, you know.
Exactly.
So what are the things that people have been talking about today?
Really, what they've been seeing in the sessions. What I found particularly interesting was, for example, Dr. Benoit Shah, the president of the British Heart Valve Society, who's one of our cardiology Twitter ambassadors, who was tweeting out one of the sessions on mitral valve repair versus replacement, and was then engaging a lot of his members of his society in the UK. And then, of course, anybody around the world who could also comment. So that was really quite interesting. And you see in our highest impressions, we do have a few cardiologists also on board and participating. So that we're very happy about that, and having these colleagues on board and creating a real heart team situation.
Were you expecting this? Because what with it being a virtual Congress, you can't really predict things anymore. So how has this performed compared to what you thought it might?
We really had no idea how it would perform, in all honesty. First thing is that we are a relatively small silo. We're very specialized. So it is somewhat smaller than other congresses. And then yes, virtually, we've never done this before, so we don't know what to expect.
Now, you have some other ambassadors who are going to be joining us this evening. Who have we got?
Well, let's start with Tamara Nyahichi, who's one of our resident members, who's joining us from Dublin.
And Tamara, you're not alone.
No, I'm not alone. I've got my little helper here. There's Marika. So she's keeping me busy today.
So, what have you been tweeting today? What has caught your attention?
I was very interested in the ECMO, especially in the acute cardiogenic shock, and looking at how to optimize that. It was a really good talk regarding unloading of the LV and looking at Impala, and with these high-risk patients. It was really interesting to see a good live discussion about how we can optimize that, and it's great again having the cardiologist as well on board to look at things on a more integrated fashion. So that was my highlight today, I think, along with the presidential's address, which was great.
I don't know if I should ask you this question, but did your daughter pay for registration?
I think she was allowed in with me, and I think that has been the case in a few previous EACTS. there have been some of my colleagues have brought their small babies along to conference.
What amazes me
yeah.
is not only are you being a doctor, you're also tweeting massively, but you cannot let up on being a parent as well. So I'm in awe how women do that. That sounds totally patronizing. I don't mean it in that way. So thank you. So stay with us. Patrick, who else have we got?
We've got Rui Cerqueira, who's also here, who's one of our Twitter ambassadors, who's also part of the residence committee, and joining us from Portugal.
Okay, so what have you been working on, Rui? We can't hear you, Rui.
You're muted.
Now, Rui doesn't talk like a 4-month-old baby, I have to say. So, Rui, have you turned your microphone on?
Can you hear me now?
Oh, yes.
Now we can hear you.
You might have to speak a little bit louder than normal because we do have
For
some
some
background.
reason, my computer decided to choose a different microphone. But that's okay.
So what have you been doing today?
I'm sorry, Roy.
What have you been tweeting on today?
So it's been a fantastic day for learning. I've been into a lot of sessions. First of all, I would like to thank this enormous opportunity for me to be having fun tweeting about topics that I enjoy talking about, and also be learning. And the highlights for the day for me actually would be the presidential address. I think our president Peter Lichter has made a very inspirational talk. His example in his life and career are fantastic, and he called our attention to collaboration and networking that we all need in our everyday life, but also called our attention to the great deficit in good quality research and evidence that still exists in surgery, at least in cardiovascular surgery. And I would like to cite one of his mottos here, that we need less eminence and more evidence in our practice.
With Twitter, how has that helped you personally and professionally to build relationships with people that you might not otherwise have met? Because, I was chatting to Tamara earlier on and we were talking about how a virtual can't really replicate a face-to-face real meeting. But Twitter does seem to be able to allow you to make real valuable connections with people.
Definitely, Roy. I have actually a very recent example, not related to the annual meeting, where Twitter allowed me to progress in my career and networking. Actually, that was how I met Jessica Luke, one of our Twitter ambassadors. I actually never met her in person, and me, her, and a couple of other colleagues have published a recent paper about our opinion on the impact of COVID-19 in training in residence training in cardiothoracic surgery. And all of the authors of this paper have never met in person, and it was great to work online during the pandemics and to be able to have some optimistic work going on.
Okay, Patrick, so are you buoyed up by the engagement levels that we're having?
Oh, absolutely. It's really phenomenal to see all the activity around the meeting, and this is really helping to get the message out from the different presentations. We'll also be working on that with the Cannibals a little bit later, but that should be kind of like preview of the different discussions that we have on Twitter.
So you're becoming a cannibal, but wasn't there some news in the General Assembly?
Yes, I was privileged to be nominated to be the next chairman of the adult cardiac surgery domain of the association.
So may I be the first person on EACTS TV to congratulate you for that. So you have to behave with decorum, even though you're still an honorary cannibal for later on. Guys,
absolutely.
Tamara, Rui, and you, Patrick, thank you very much. We will, as you say, we'll hear from Patrick a little bit later on as well. So thank you so much for that. And it's time now to welcome back Rafa Tabada. For those of you who don't know Rafa, he's a heart surgeon at Navarra University Hospital in Pamplona in Spain. So you're the head chef for people like the Cannibals today. You've led the educational committee putting together the ingredients for the program. So what are your overall impressions of today?
Hi, Roy. Well, today has been another very intense and interesting day. Loads of different sessions running at the same time. I've had my back glued to this chair again today. So much to see. Catering for everyone, again, another fantastic day.
Excellent. So what you're going to do now is you're going to highlight 3 of the many presentations that people have been able to see today. And hopefully we can take an extract. Some of them, we're cheating really because we're just showing the conclusion or the summary of the presentation, a little bit of the Q&A as well. But hopefully that will give people a flavor of what they may have missed and can get the gist really of what that presentation was about. So can you just tell us a little bit about the first presentation that you've chosen for our extract today?
Okay, so it's not an easy task, Roy, choosing just 3 presentations out of the few hundred that we've had today. So this one is out of the usual type of presentations, because this is discussing about this GAL KO, that is a knockout for a galactosyl transferase enzyme, which appears to potentially have an immune effect on the patients receiving bioprosthesis. So this is something which is not usually discussed, and we thought it was interesting.
Okay, so let's take a look at our first video.
So I want to end summary, outlook, future. There is a link between cardiac surgery, cardiology, allergy, and immunology. Clinicians have to become aware. I'm against critical lowering of age limits, surgical as well as TAVI. The community has to become aware of the GAL syndrome. The regulatory body and notified bodies have to become aware of the alpha-GAL. Sugar epitope and the black box warning, that's my opinion, should be installed, that patients are informed that they can become sensitized. And the commercial valve industry has to provide GAL deficient bioprosthesis for TAVI and surgical valves.
I have one thing that is not entirely clear to me, or that I don't know fully, is what's the difference in reaction between younger and older patients? Do they all react from an immune point of view against these alpha-gal bearing prosthesis, or is there a difference in immune response between the young and the older patients?
I think it's this is a very good question, but it has to be based on what do we see with the patients, young patients and old patients. And so we know that patients above 70 years, these valves endure much longer. And those implanted in young patients have really sort of like a rejection process ongoing. So it was quite interesting for us to see that even in old patients above 70 who received the TAVI, there was an immune activation, which I have seldom seen. So I think there's the young patient has a competent immune system, and the older patient too, but basically somewhat attenuated.
I have a question here from one of the panelists, Dr. Welter. Should commercial tests for antibodies be routinely added to patients undergoing heart valve replacement?
This is also a very, 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 very good question. There are 2 issues which I want to stress. The animal models which are currently utilized by the industry, like industry representatives come to the clinician and say, well, we have tested valve XY in sheep, and there we have got great evidence that is working and we are happy. This is completely wrong, because these animals don't reflect the human situation. So my notion was, and that was since 2000, I was always claiming If you want to test new valves, which are decellularized, which are gal depleted, whatever, if you want to make evidence for clinicians, you have to go to South Africa or to America or to Asia, where you have got baboon systems running, where these animals, they have cytotoxic IgM antibody against gal, and there you can monitor this. And the second question is, it's very unfortunate there are no commercial available gal ELISAs, which are standardized, which are validated. So we are here like it's very, very undefined at the moment.
Hendrik, I have to point out a cultural thing, that when there are British people watching, you can't do that. It means something very rude. Anyway, Rafa, what else do we have?
Okay, the next one is about what we call TCAP, that's total endoscopic coronary artery bypass. And this is in line with what we spoke about yesterday, making or doing the procedures more minimally invasively. So this is talking about operating on somebody's heart with a robot.
Okay, so let's take a look at this presentation.
What does TCAP offer the surgeon? Well, it offers less strain during the operation because we're sitting instead of standing, and pretty much better magnified visualization of the target. But it also has some drawbacks, including an intense and steep learning curve, longer time in the operating room, and therefore less ability to do multiple cases in a day. This is a picture of one of my PAs who's acting as the fourth robotic arm pushing down the shoulder while we're doing TCAP surgery. But really, the offering to the surgeon is the satisfaction of a less invasive but equally efficacious solution for their patient.
Very short but sweet there,
yes.
But a powerful message. How pervasive is this? Is this becoming very widespread?
It's very slowly taking pace, more so in the US than in Europe. But I guess that as time goes by, it will spread out and become more used.
Okay, so what is the third topic that you'd like to highlight of what's been happening today?
Well, third topic is we are surgeons, but it's about treating patients by other means following surgery. So it's how to optimize medical treatment for patients following coronary artery bypass graft.
Okay, so let's take a look at this video.
So, as for take-home messages, we'd like to state that full compliance with guideline-directed medical therapy remains low before and after surgery. Full compliance is associated with the decrease in mortality at 1 and 5 years after surgery, and we should monitor compliance with the medication before and after surgery, and we should implement strategies to monitor and improve adherence after CABG.
Okay, so 3 short but sweet extracts from a very, very busy day. What is happening tomorrow that you'd like to bring to everybody's attention?
Again, plenty of things happening tomorrow. We'll start in the morning with a very interesting thoracic session on rehabilitation and ERAS. Then we'll have other sessions on transcatheter techniques. Indeed, we have the trial and evidence update session. This is a plenary session in which we will be discussing very, very interesting topics. And also, I would like to point out the guideline session in which the newest guidelines that the association is producing will be presented.
Okay, well, we will see you again tomorrow. Thank you very much for your contribution and bringing together. It is a difficult task for you actually to actually select only 3 of what's been happening during the course of the day. So I do appreciate the work that you're doing on that. Thank you.
I hope you get it.
Well, you mentioned the prehabilitation session. That's with Tim Batchelor tomorrow morning. I'm actually going to be talking to Tim a little bit later on. Excellent. And you also mentioned the trial update session, which is of huge interest to delegates. And I'm now going to welcome some guests who are going to be talking about that. We have John Mandrola, who'll be the moderator of the trial update. This Week in Cardiology podcast is what John's involved in. Highly respected blogger who describes himself as, and I love this, a medical conservative cardiac electrophysiologist, cyclist, and learner. Is that accurate, sir?
Yes, thank you, Roy. Thanks for having me.
Excellent. And we've also been joined by Professor Sanjay Kaul, who's going to discuss the TAVI trials in the trial update session. Sanjay is the cardiologist at the Cedars-Sinai Medical Center in Los Angeles, where he's also a professor of medicine. So, John, if I can start with you, what are the key things that you'd like to share?
Well, I mean, it's always, well, first of all, it's a big honor to be a moderator in this session. I mean, I'm not a heart surgeon, and so it's just so exciting to be involved with this. I'm not the only moderator. There are a couple other moderators, but it's going to be a good session. We start by looking at the syntax score, and we have one person who says it's not very predictive. Another very famous person says it is, and then we have Dr. Brophy from Canada, always a Canadian, sort things out, and so that's the
to be polite and sort things out.
What's that?
Canadians are always polite, so they'll politely sort things out.
Yes. And then, then we're going to hear about the radial artery as a conduit. And again, it sounds like we have a couple of viewpoints, but I think the gem will be in the TAVI and SAVR updates. Sanjay can speak to this more than I can, but we'll have a meta-analysis about long-term outcomes. We'll hear about an update on Partner 3, which obviously a huge trial, and also a TVT registry update, and then Dr. Kaul will put it all together. So, I mean, it's going to be great.
It's an ongoing thing. I mean, this must be very interesting and exciting for somebody like you who is creating podcasts and writing all of the time. This is an area that is changing so much.
Oh, I mean, come on. The one of the biggest things in our hospital is TAVI, and I mean, it's just on everybody's mind, and I mean, everybody's wondering about how these valves are going to hold up. It's a more non-invasive procedure, so patients want it, but we also need data. And so just in terms of someone who's interested in evidence like myself, I mean, it's huge.
Okay, Sanjay, what sort of things would you like to share?
Well, I think TAVI clearly has revolutionized the management of patients with symptomatic severe aortic stenosis. So it's quite appropriate to provide an update in this arena. And I think John already mentioned what the program is going to emphasize. But my role would be to sort of provide a critical appraisal of the overall evidence base for low-risk patients for TAVR. And I'll ask some specific questions, what should be the strength of evidence to expand the recommendations for TAVR for low-risk patients. Currently, the guidelines focus on inoperable, high-risk, and intermediate-risk patients. And the guidelines preceded the low-risk pivotal trials. So the question that needs to be asked is the current evidence base sufficient to inform the guidelines, and at what class of recommendation and what level of evidence? And what's also important is that the pivotal trials only included select patients. And so what are the factors that mitigate against universal adoption of TAVR? Which patients should stay with SAVR in the foreseeable future? And then last but not the least, what are the lessons that we have learned from these pivotal trials, and how can we improve and optimize trial design and conduct based on what we have learned from these pivotal low-risk trials? So it's an exciting session. I look forward to it. I'm not a surgeon, or neither am I an interventional cardiologist, so I am honored and delighted as a as a nonpartisan arbiter of this evidence to participate in this session.
All right, John, I have to say you're looking good today, because I know something about you that most people don't know. You are so committed to your profession. Would you like to share what you actually did earlier today?
Oh, yes. So I was honored to give a talk about atrial fibrillation ablation at a surgeon's meeting, and I was tasked with giving not a contrarian, but a truthful look at the procedure that I do. The thing of it is my little iPhone thing was giving me alerts at 8:30 this morning that my talk was coming up, but it was actually 8:30 European time. So I woke up at 2:30, woke up at 2 actually, and I gave the talk. Now I tried to just do it without a video monitor, but the lady from France said no, I had to take a shower and get cleaned up and look proper. So yes, then I went back to sleep.
Excellent. So there's dedication for you. And can I also ask you, why are you so active with your blog and your podcast? I mean, don't you have enough to do? I mean, particularly for a private practice, non-academic cardiologist.
Yeah. Lots of people ask me that. I've never worked harder, and I'm in my 50s. No, I really love evidence. It came to me later in practice. I just did things for 10 years and really didn't ask too many questions. But as time went on, I started asking questions, and it slowly got into it. And now I'm really addicted to critical appraisal and learning about this and communicating. I think the main reason, though, is that in private practice here, I have no fellows, I have no students. It's really nobody to teach, and I feel like social media allows us to be kind of teachers and educators on the world stage, and so I really love it.
So it's the only way you can make friends, basically.
Well, I don't know about that. I sometimes make some enemies.
Sanjay, what are your views on being in Los Angeles and attending a virtual congress? Does it work for you? What are the pros? What are the cons?
Well, I certainly don't have to travel to attend, and so that's a big plus. What I really like about the Zoom conferences is that people who don't have the ability to attend are now able to attend. So it's not surprising that you have such a expansion of the attendance, and some of the questions that they ask in the chat room and the site chat rooms, they're phenomenal. And so it's like true democratization of evidence, and so that's the big plus for me.
Yeah, everybody's being so open-minded and very positive about it. Guys, I hope the session goes well for you. I'm absolutely sure it will. They will be in very, very safe hands. So thank you very much for joining us tonight, John Mandrola and Sanjay Kaur. Thank you. Tim Batchelor is a consultant thoracic surgeon at the University Hospitals in Bristol in the UK, only about 15 miles from where we are right now. So welcome, Tim. You're going to be facilitating a session tomorrow morning at 8 o'clock called Prehab and ERAS in Thoracic Surgery. First basic question, forgive me, what is prehabilitation?
Yeah, so prehabilitation is pre-operative rehabilitation. We know what rehabilitation is. You become unwell and then you do something to get better. This is about trying to preempt that. So getting strong for surgery. And if you can get strong, then you're more likely to withstand the traumas of surgery and everything else that we do to you in a hospital.
So you're really giving a central role to the patient rather than doing things to them to help them. You're showing them a patient pathway so they can help themselves.
That's absolutely right. And as you know, historically, patients have been a passive recipient of their care, a passenger in the process, if you like. And this is about involving them right from the very beginning. So we get them fit, we educate them, we manage their expectations. They know what to expect on the day of surgery, and they know what to expect after surgery. So we set them goals after surgery as well. So they're completely empowered and have ownership of their pathway.
So what is your session going to cover tomorrow? You've got 90 minutes.
Yeah. So two halves, really. We're talking about prehabilitation. We've got some fantastic speakers from Germany, from Cambridge in the UK. And then in the second half of the session, we're going to be talking more about enhanced recovery after surgery in general. So again, we've got some nice speakers from Hong Kong and from Germany and from Switzerland, looking at how to implement an enhanced recovery program, then how to sustain it as well, because that can be a real challenge.
So why is this topic an important new development for thoracic surgery?
Yeah, so again, historically, we've tended to work in our own little compartments and our own silos. So surgeons have looked at the operation, anaesthetists looked at putting people to sleep and their pain relief, nurses on the ward and what have you. And this is actually looking at the entire patient pathway, breaking it down into its myriad little pieces, trying to improve each little bit, and putting it all back together again. And so a complete change in focus from referral through to discharge.
So who would be the sort of person who'd get the most value from actually attending the session? Anyone involved with care of the surgical patient, because we work now as a multidisciplinary team. We've moved away from those silos, if you like. So not only is it the surgeons and the anaesthetists, there's the physios, we've got the nurses at the different stages of the patient pathway, we've got pharmacy, anyone else who you can think of that might be involved. Now, how did you get so passionate about this subject? Because you've been involved in this for nearly a decade.
A long time, yeah. So I was actually introduced to it by one of our head nurses who'd heard about it in another specialty, in colorectal surgery, where it was born. It was born in Denmark in the 1990s. And they'd had great results. It was popularized worldwide through the EACTS Society, but cardiothoracic surgery was really a bit of a latecomer to the party. So what we were able to do was look at the colorectal pathway, the urology pathway, the gynecology pathway, take out those components which seemed important to the thoracic surgical patients, incorporate those into our pathway, and then at the same time, parachute in new evidence-based thoracic surgery specific elements.
Are there, or is there data that supports why you'd need to do this? Is it a better experience for patients?
Definitely is. So we're now getting the results coming through, and we're able to see that patients on an EACTS pathway are more likely to have less complications. They are going to return to their normal quality of life quicker. As a byproduct of all of this, they spend less time in hospital, and costs are lower for the hospital as well.
All right. Well, I hope the session goes really well tomorrow. It starts at 8 o'clock in the morning, so you need to have an early night. Perhaps there should be an alternative title for this session, which would be How to Listen to Nurses.
I couldn't agree more. I've learned a great deal from doing that.
Jim, thank you very much indeed. Good luck.
Thank you. Bye-bye.
Well, it's time to get our teeth into our Cannibals session for this evening. These are surgeons who eat science, and to find out what's on the menu later on tonight, I'd like to welcome back Patrick Myers. Hello, Patrick. You have your Cannibals standing by to feast on what they've been learning today. So who have we got? Would you like to introduce them again, or shall I?
Maybe first going back a little bit, I think we do have two honorary Cannibals tonight with John Mandrola and Sanjay Kaul. I mean, they are interested in data, they are interested in evidence, and they espouse the same ideals as the Cannibals. Excellent.
So who do we have?
So we have Edu Quintana from Barcelona, and Victor Dayan from Montevideo in Uruguay.
Hello. So we are rejoined by Edu and Victor. They were with us last night as well. So what are you feasting on this evening, if I may?
Well, we can go back to the Edu is still muted. But
turn your microphone on, Edu, please. Thank you.
Yes.
So what can I focus on?
We'll go back to the three segments.
Okay.
Yeah.
So, Victor, TCAP, any thoughts?
Okay, hi, good afternoon. How are you? Okay, it was a very good day today in Barcelona. It feels like being in Barcelona with Sagrada Familia always in the background, so it was a really nice day. And first of all, I would like to congratulate Patrick because he passed me as Twitter influencer. Not only about that, but because of being the new chair of adult cardiac surgery. But I'm still above Domenico Pagano. That's a good thing. That's a good thing. So
you don't do competition then, really. You're not very
quite. One of the sessions that I would like to comment about is the big surgery, small incision surgery, in which very world-renowned surgeons presented the short and medium-term data regarding minimally invasive coronary artery bypass revascularization, showing that they have really low the level of 0 to 1% operative mortality, 2 or 3 days of hospital admission, really impressive data. And my position here is like a devil's advocate. I come from South America. I belong to a medium volume center of cardiac surgery, a cardiac surgery center which represents about more than 80% of cardiac surgeries around the world, right? So what's the external validity of that data to implement that great technology as a standard of care? So when I see that data, I remind myself of those slides of Tyrone David in which he shows his 20-year follow-up of David procedure, in which the redo of those patients is almost 0% after 20 years. So but that's on Tyrone David's hands, right? So Tamara, in a couple of her tweets, I don't know if we have one of those tweets there, she mentioned exactly this issue. So that's it. So Mark Rule mentioned that this is the panel chat in which he mentioned that infections are rare. Even though infections are rare in minimally invasive, sternotomy is not the future. So Tamara, very opportune, mentioned, okay, so if we are going to do minimally invasive cardiac surgery, how are we going to get there? Because our standard training is through conventional cardiac surgery. So I think this puts into the table, how are we going to confront future training in cardiac surgery? Will we get our residents right through minimally invasive cardiac surgery, like Dr. Borger mentioned a couple of years ago in a meeting in Belfast? Or are we going to make them go through the typical steps of conventional surgery and then go to minimally invasive? I think that's an issue that we academic centers need to consider before embracing these minimally invasive techniques.
Excellent.
If I can say something on that, which I couldn't agree more, Victor, is a concern on the impact of training with engagement of these new technologies. But that's clearly will have an impact. But before that, I mean, even for the average cardiac surgeon that has a superb operation, which is CABG, said yesterday by David Taggart, for almost 70-80% of patients with coronary disease, a Lima2 LAD and 2 veins will do an excellent job. And that's very consistent with a lot of external validity of the procedure, that it's spread worldwide. We know it functions. We know it functions even better than stents. And now we're trying to, step farther. Even for us, for experienced surgeons in CABG, it's difficult to take these steps towards minimal invasive, first mid-cap, then multiple grafts through mid-cap, arterial, and then moving to robotic. It's a challenge for already trained surgeons, let alone residents. So we don't have to forget that we have an excellent operation, and we cannot fail to thousands of patients worldwide if we engage with these therapies, because many will pay a big price. I don't know if you will agree with that.
As a non-medical person, I mean, my understanding is that patients much prefer the idea of minimally invasive surgery because it's not as disruptive. They don't get a big scar and everything. So is there pressure coming from patients, or is it pressure coming from surgeons to do it? Because it's not as good or as effective as doing it the way that surgeons do things all the time. Is that correct?
Well, if it's obvious that if you can do the same exact thing, obtaining the same result with less invasion, we have to do it. I mean,
Yeah.
that's clear. I mean, if we can fix something with a catheter, of course, that's best for the patient. That's what we all want. But we don't want to trade off any of the good, excellent long-term results that we have with the available therapies. I think the movement comes from both patients. They ask that, of course, and they have to. And also we want to improve. We want to do better. We want to improve our outcomes. But there is a learning curve, and it can be dangerous sometimes. So I would say at this point, it's not for everybody. It's going to be a long way to train on that. And after you've trained the average general cardiac surgeon, you have to see how you train the residents, which we have this dichotomy. Either you train them straight to these minimal invasive techniques, or you train them progressively on conventional techniques.
All right, Victor, I sense that you want to contribute.
Yes, I would like to complement what Edu said, because it's quite like that, right? Dr. Balki, in his presentation, he said half of that presentation was, what does TCAP offer to the surgeon? So not only to the patient, but to the surgeon as well. And what he highlighted was that above all, it offers satisfaction. So I guess surgeons get like a huge thrill of, it's really important, of being able to perform that very important surgery, which brings a lot of improvement to the patient and a lot of satisfaction to the patient. But we need to be very cautious, because as Edu said, CABG, regular CABG is a procedure that has very low operating mortality. So we must be very careful trading off that very low operating mortality for satisfaction, even for the surgeon or for the patient, when we are not properly trained on that.
Okay. Patrick, what are you going to focus on?
Well, if we go up to the last video, which was GDMT, guideline-directed medical therapy. That was a great paper from the group from Lisbon, where they looked at how many of their patients after CABG actually followed the guidelines in terms of medical therapy. And we know from many trials, from Syntax trial, et cetera, that overall CABG patients get less guideline-directed medical therapy than PCI patients in all these trials. And this showed very well that only 50% of the patients received the medical treatments that they should receive after a major procedure, like a coronary artery bypass surgery. And also at the same time, that had an impact on their survival at 1 year, but also later at 5 years. Their survival, if they received guideline medical treatment, they had much better survival. And so that's an issue for us as a specialty, is that we're not just technicians, we're not just surgeons. We have to do a better job of following our patients, and that they leave the hospital with optimal medical therapy, and that we make sure that they receive that in the years that follow. Now, we're not the only ones. The whole heart team is failing these patients, because if we look also before their coronary artery bypass procedure, there were just 13% of the patients who were already receiving all of these medications. Now, admittedly, they didn't likely have all the indications to have all these medications, but those patients who had a previous acute coronary syndrome, a previous heart attack, a previous stent, well, there were still 15% of these patients who weren't receiving optimal medical therapy. So that's even lower than post-surgery patients. It should have been 100% if we want a good outcome. And so we have to do a better job at taking care of our patients as patients after the procedure, and not just after the surgery.
Okay.
And during the surgery.
So you just had your main course as Cannibals. Do you have any afterthoughts, or would you like to make any dessert comments before we bring this session to a close? No, you're full. You've had your meal and you're happy.
I think we're eager, and we need to rest to be prepared for the trial session that is coming tomorrow. That seems really, really exciting.
Okay.
Don't you think?
Absolutely. And I like having also a lot of cardiology Twitter ambassadors, because it'll be interested to see what they have to say about this session.
And also Rafa is pointing that we should discuss a little bit on the GAL presentation that was mentioned earlier. And that's basically, it was a great talk by Jan Ankersmit, in which we're looking at tissue valves that are available commercially. They come from different animals and they express this sugar epitope, like some of the antibodies that are sometimes present in humans can attack those. And this is related to an anti-GAL syndrome that can be associated with rash, hives that I would say the average surgeon, maybe 50% of surgeons are not aware of that. I got aware about this reviewing a paper not that long ago. So that's something that we all should know better, that these commercially available tissue valves have this antigen that can trigger, immunitary reaction, and also potentially associated with structural valve deterioration, early structural valve deterioration, and it happens with surgical valves and TAVI. So he was pointing at many things. One of the things was he was against, moving the implant of valves, tissue valves, to younger populations because they can destroy these valves fairly. And we know from trials that mortality is higher when you implant tissue valves in young patients. And then just to finish, the tissue valves are sometimes tested in animals that don't express this immunitary reaction like sheep. And he was making the point that it should be tested in baboons, that they have similar immunitary system to humans. So very interesting, and it's not reported on the valve box, let's say.
That brings our cannibal meal to a close for this evening. I hope you have a very restful evening. If you were tuned in last night, you'll know that Victor will almost certainly be going for a bottle of wine next. He is absolutely adamant that he shares it with everyone nearby. So it's not just for him. Gentlemen, thank you very much. We'll see you again tomorrow evening, I hope. I look forward to hearing your comments then. Enjoy the rest of your evening. Thank you. Okay, and it's time now to go back to Domenico Pagano. Hello, Domenico. So what sort of a day have you had? I mean, I must be honest with you. I was a little bit nervous earlier on because we were about 3 or 4 minutes to go and nobody was waiting in the green room here of the virtual TV studio, including you. And I knew that you were all in the General Assembly, but I was so pleased to see so many friendly faces when you joined us. So what sort of a day have you had?
It's been a great day. It's been busy. Look, the guys here, my colleagues are running the EACTS TV show. They're working with you. I've been sitting back, flying the desk. It's been fantastic. We've had a lot of people coming to sessions. I've engaged with on the platform with partners from industry, very positive comments, 1 or 2 glitches, 1 or 2 people still not with the right attitude towards we are all in this together, but they are the minority. And
I did actually hear one example of somebody who did get quite upset and quite angry, and he was raising his voice to complain until it was pointed out to him that he wasn't complaining to the help desk, he was complaining to the waiting room, and there was nobody there to listen. So if you have something to say, anybody, if there's a problem, can you please make sure you're talking to the help desk, because they are brilliant, aren't they? They're turning things around really, really quickly. So I think that was the example that you were thinking of, actually. Somebody mentioned earlier on about the presidential address and how inspiring it was. What is your take on the presidential address today?
Well, I thought he was spot on. I know that he's changed his presidential address because of the circumstances. And that's what you want to hear in these circumstances. It's an opportunity. You want to look at the future, and you want to reflect on the things that you should be doing, and the basic values come out again. And I think he was absolutely spot on. I'm really proud to have served with Peter as a president.
Excellent. And we had the General Assembly meeting just before we came on the air. Yeah. Can you summarize the General Assembly?
Yes, it's been a good General Assembly. The bad news is that they confirmed me for another 3 years.
Is that now? Wait a minute. Forgive me, but is that bad news for the members, or is that bad news for you?
Well, I think it's probably bad news all around, isn't it? And then we've had a new crop of people to join, colleagues to join. But the most important thing is that we've changed the constitution so that now we have different ways of appointing key people in the council where they've got the expertise and they're not necessarily doctors, like business people and so on. And this will equip the council to try and address the issues that we're running now and the transformation that we need for the future. So that
is that really moving with the times, that the situation is excellent. Okay, so what are the big things that are happening tomorrow? I know there's one big thing happening tomorrow on the final day.
Well, yes, I mean, there are lots of big things tomorrow, and it's the final day. Tomorrow evening here, we'll be doing the exchange of the chain with the new president. But I have to mention again the trial and update session. Last year, we ended up in 2 programs at the BBC, still running. It's had a great influence on interpreting the data. It's very educational. And so it's one of the most important. But also, we have the AATS, which have not been at the SCTS for a long time, that are coming back. Now, this year is the spirit of collaboration. They had the 100-year anniversary. They had to cancel their meeting, and we offered them a session. So we'll be having a session with the AATS, the first organization, the eldest organization, which will be chaired by an ex-Secretary General of EACTS, Bruce Keogh, and an ex-president of the STS. So that's a session to watch. And it's later on the Saturday because we wanted to make sure that the time difference. And we have 5 past presidents of the AATS in that session.
Excellent. So far, even with fewer glitches today than we had yesterday, and there weren't a lot yesterday, there was a message that I saw on WhatsApp, I think earlier on, from someone saying that he's not really somebody that likes to send emails around saying, well done, everybody. But this particular person, who I won't name, was absolutely delighted with the bravery on the part of the committee to have made this decision and to carry it forward. So how does that make you feel, having the team around you?
Oh, fantastic. I mean, this is it's been a really, truly pioneering exercise. I know where we're coming from in the middle of May, very dark days. I never thought we would be here today. And actually, we are. And this is just a testament that whenever you got a difficulty and you got an obstacle, it's there to be to overcome. So it's a lesson for us all. Thank you to all the people that helped in this teamwork. I really showed a video today from Sim of how many people are behind the scenes to make these sessions. And it's really daunting to see how many people are actually doubling up to do this. So thank you.
Yeah, I'm getting a huge amount of support from the guys in Rennes. And I saw a little GIF, an animated image that was being circled around today. And I thought, actually, to say thank you, I think we should show this little thing for all of the contributors today. I thought that was pretty cool. A bit childish maybe, but it's perfect. Anyway, Domenico, thank you. Have a splendid evening this evening. And I hope you have a great day tomorrow again. And we'll see you again tomorrow evening. So thank you very much.
And thank you, Roy. You're doing a great job. Thank you for your help.
All right. Oh, I got a round of applause as well in my ear. Anyway, that's it for today. We'll be back tomorrow at the slightly earlier time. We're going back to the normal time. Thank you to all of our contributors today. You've done a great job. We are very keen to hear what you think as a delegate, to explain what your experience has been, because that would be really, really helpful. There does seem to be a consensus amongst everybody that no matter what happens in the world post-COVID, that there is still an opportunity to have something virtual, which, as it was said earlier on, it gives people an opportunity from all over the world who might not normally be able to attend a congress like this to be able to take part. So that's all from me, Roy Shepherd. Have a great evening or a great day, and we will be back tomorrow. Bye-bye.